Welcome everybody to the sixth session for the anatomy tutoring session. So tonight we're going to be going over some respiratory anatomy, histology, and embryology. I am going to be one of your hosts today. I'm Dr. Haggerty, co-founder and coordinator of Anato-Bee. I'm also an assistant professor at Thomas Jefferson University. And I will be hanging out with you all tonight as our wonderful medical student and osteopathic student presenters grace us with their presence and go through some questions for us all of the lectures that we have previously viewed before coming to this session. A couple of announcements. Just so you all know, you should be getting information coming in on our Google Classroom about the anatomy sessions, the links to the sessions and everything. You should have also gotten your links to register for the VH dissector or to use that for your studying purposes. If you haven't gotten access to VH Dissector or also to Jove, please email me. I'll put my email in the chat once I'm done with this. You can email me or you can email Anatomy directly, and we'll make sure that you get registered for those things. You can also, excited to announce, you can also tentatively put in your calendars March 14th and 15th. That is going to be the tentative weekend or dates for our regional competition. Let me just double check. 15th and I went back to the I am bouncing all over years here. 2026, March, second weekend, March 14th and 15th. We have some really great host institutions lined up for the regional event. We're not willing to share that information just yet because we just want to make sure that we can confirm with you a few things first. But we're really excited to have you all here and get started with that. I'm pretty sure that's all the announcements I have, other than we wish you all a really great fall break and Thanksgiving if you are celebrating this week. Does anybody have any questions before we get started? Let me just check the chat. All right, and I'm going to hand it off to Dr. Frank.
Okay, well, welcome back, everyone. Good to see everyone again. And this evening is going to be all about the respiratory system. Our first presenter, which will be going over the anatomy of the respiratory system, is Emilie Savaikie from the Pacific Northwest University College of Osteopathic Medicine. Emilie is from Auburn, Washington, and she graduated from the University of Washington with a Bachelor of Arts in Political Science. She is currently a second-year medical student and has interests in OB/GYN and emergency medicine. Emilie previously worked as a CNA in the ED in a school health setting, as well as volunteering with organizations such as the Now I Lay Me Down to Sleep organization. In her free time, she enjoys bike rides and playing Minecraft with her kids. So with that, I will give it over to Emilie.
Okay, thank you, Dr. Frank. Let me share my screen. Hope everyone's doing great on this weekend before a longer break I assume everyone's getting. So let me share and hit play. Okay, so covering the anatomy part of respiratory, and we've got some lecture objectives, such as describe the structure and function of the respiratory system, including the gross structure of the lungs and trachea, identify the structures at the hilum of the lung, and discuss movements of respiration, including the role of the diaphragm, the intercostal muscles, and other accessory muscles of respiration. So I wanted to create a quick warm-up question. The process of moving air in and out of the lungs is called A, respiration, or B, ventilation. So I'll give you a few moments to select the right answer.
let me know when you'd like to end the poll.
Yeah, sure. If we got enough people,
Yeah.
with more than 2.
Yep, we have 70%.
Okay, excellent. So the answer is B, ventilation. And a lot of people said A, which is okay, because so respiration, when we talk about it in terms of medicine, it's the biological process of gas exchange, both occurring at the lungs and at the cellular level. And there's more on this later. But colloquially, respiration equals breathing. So if you said respiration, we'll give you half credit there. So a quick going over the process of ventilation. So the diaphragm contracts, the chest wall expands, and volume increases. So we see the forces there. And so the lungs are bigger, but according to Boyle's law, and I don't think you know exactly who, but when volume goes up, pressure goes down. So then we're going to see air moving from high to low pressure. And the diaphragm relaxes, chest wall contracts, and volume decreases. So Boyle again, you drop the volume, increase the pressure, and air moves from high to low pressure. So we're going to skip ahead here to get to the questions here a little bit quicker, but a couple more things I just want to cover. Thoracic cavity contents. So we've got pulmonary sacs, and they are more lateral. There's one lung in each sac, the pleura and the associated structures, and the left and right are completely separated. Along with the mediastinum, which is medial, and that was discussed last session, I believe. Just also note in the thoracic cavity, there are 5 birds, which I'll get to later. The pleura, so it is a serous membrane. So the internal part of the membrane is visceral, and the external is parietal. In the middle, there's some form of fluid. So for the lung pleura, the visceral is adhered to the lung tissue, and the parietal pleura is adhered to the thoracic wall, diaphragm, and mediastinum. Whoops, I want to skip that one. So we're going to go up to slide. Sorry about that. Okay. And then lobes and fissures on the right lung. For the lobes, we can see a superior lobe, a middle lobe, and an inferior lobe with the fissures dividing the superior and the middle lobes of the horizontal fissure and the oblique fissure, dividing the middle and upper lobes from the inferior lobe. For the left lobe, or left lung, you have 2 lobes, superior and inferior. Since you only have 2 lobes, you have 1 fissure. So that is also your oblique fissure. And then lastly, before we get to questions, how does air get in? So we have a tracheal bronchial tree, which contains 1 trachea, 2 primary bronchi, 5 secondary bronchi, and about 20 tertiary and segmental bronchi. And quickly going down this list, we have our trachea, which is a continuation of larynx, and it's anterior to the esophagus, and it has these C-shaped cartilaginous rings that go around, kind of like a vacuum cleaner, to prevent collapse of the vacuum hose due to a vacuum, so it doesn't collapse on itself. And then you have your main bronchi, left and right, and they bifurcate at a structure called the carina, and that's at the level of T4 and T5. And note that this is looking backwards, so the right is shorter and similar angle to that trachea. And then lobar, secondary bronchi, there's 3 on the left, 3 on the right and 2 on the left. That matches the lobes. So when we go to ventilation to respiration, we've already talked about those structures, and then we go down to our tertiary bronchi or segmental bronchi. Then you have 4th, 5th, 6th, 10th generation bronchi. And then you get to your conducting bronchioles, which has no cartilage. And then to your terminal bronchioles, about the 16th generation, where you finally start with respiration. So respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli, which we will get to a lot more, I would assume, in histology. And then lastly, I just want to cover the bronchopulmonary segments, that each lobar bronchi contains 2 to 5 segmental or tertiary bronchi. And each segmental bronchus supplies a bronchopulmonary segment. And these segments can be individually removed. They all have their own blood supply and their own connection to the trachea so that you can remove each segment. And I don't think you're going to be responsible for naming all of them, I would hope. But there are 4 to 5 in the left superior, 4 to 5 in the left inferior, 3 in the right superior, 2 in the right middle, and 5 in the right inferior. We can skip those. So let's start with the questions. Okay, so case 1. I decided to write this a little bit differently that you might be used to, so I'm going to give you a couple case studies. You are an emergency room physician at Anato-Bee General Hospital. You're presented with a real medical case. Irrelevant medical details and identifying characteristics have been changed to protect patient privacy. And this did not happen to me. Okay, a 29-year-old pre-medical student presents to your emergency room after a visit to the dentist. 30 minutes earlier, while having a permanent crown installed, the dentist accidentally dropped the crown during the patient's inhalation phase of breathing. She reports no pain and cannot tell if she inhaled or swallowed the crown. She denies globus pharyngeus, which means that you have that feeling that something's stuck in your throat. That's what we call that. Cough or difficulty breathing. Her past medical history provides no insight to the case. She takes an albuterol inhaler for asthma. She has no known drug allergies. Her pulse is 65 per minute. Respirations are 20 per minute. Blood pressure is 112/74 millimeters of mercury. And temperature is 37.1 degrees Celsius. And her oxygen saturation is at 97% on room air. All of that is perfectly normal. On auscultation, so listening to the lungs, you hear less breath sounds on the right lung, except for an area between the clavicle and the trapezius on the right side here. But you hear a faint biphasic, which means you hear it when you're breathing in and out, a wheeze, so a little bit of a high frequency musical pitch that goes by. Posterior, you auscultate the same sound at the level of T5 between the scapula and the spine on the right. Otherwise, long sounds are cleared auscultation bilaterally. Heart has clear sounds. No object was visualized in the throat, which shows moist and pink mucous membranes. And if you don't know what a crown is, that's what that looks like. And here is a chest x-ray. If you haven't, we had one of these. This thing here is not normal. And that is the location of that tracheobronchial tree. And it kind of intersects with that object there. So question 1, based on your knowledge of anatomy and physics, if the crown was inhaled, where would you most likely find it? The right superior lobar bronchus, the right inferior lobar bronchus, the left superior lobar bronchus, the left inferior lobar bronchus, or the lingular bronchus? So while you're putting in a poll, just remember that if you look at this, one side is a little straighter and heads more inferiorly than another side. So have we got enough response, Dr. Frank or Dr. Haggerty?
Emilie, can you see the responses coming in or no?
I can. Yep. I see mostly people pick choice B, which is correct.
Perfect. Can you see the
Fantastic.
percentage participating?
I could not. It just showed more. I just saw lines of relative amounts.
We can then help you with that. And I just wanted to make sure. I didn't know you couldn't see how many people are participating, but I think we can end the poll now.
Okay. And just to give you the, go ahead.
I did end it. And I shared it.
Thank you.
Yeah. So
I saw the results, yeah.
Yeah, when I get over 70%, then I'll close it, unless you tell me to close it earlier.
Thank you, Dr. Frank.
Thank you, Drs. Frank and Haggerty. So yeah, the right inferior lobar bronchi. So notice that it just goes kind of a straight shot right down here, and eventually it's going to get down to a size where it can't fit. And at what vertebral level did the crown leave the trachea to enter the right bronchus? So I gotta remember where that bifurcation is, which is called the carina, and think of what level that would be at. Oh, I see some things in the chat, so I'm gonna go look here. Okay, see the results. If you want option C, and option C is correct. Good job. Oops. Oh, wrong one. There we go. T4. Since everyone saw the answer, which is the best method of removing the foreign body? So now this part is to make you think on how easily can you access the inside of a bronchus. So A, an open approach where the sternum is cut in half vertically, the ribs are spread apart, have an assistant displace the beating heart superiorly and anteriorly while you locate the right main bronchus after cutting pleural and pericardial tissue, perform a bronchotomy and remove the foreign object. This requires 5 to 7 days of hospitalization, 6 weeks of recovery and rehabilitation, and about 6 months of healing to a position where you're probably worse off than you started. B, video-assisted thoracoscopic surgery, which is the same as A, but you don't open everyone up. You use a little tube and you go through the thoracic wall without having to open it up. C, prescribe an expectorant to help the patient cough it out. D, use a flexible bronchoscope to remove the foreign body. So a bronchoscope goes down the throat to the trachea and down the pulmonary tree. E, use a flexible endoscope to remove the foreign body, which goes down the mouth into the esophagus and down the stomach to remove a foreign body if you see it. So we can start the poll there. If you could, please.
Okay, I'm going to end it.
Okay. Hopefully we got that right. Yep. Somebody wanted to do an open report and cost the patient's family lots of money and time, and I don't think they want to pay for it. So, but that's okay. All right. Yeah, so, okay. Continued. 30 minutes after the pulmonologist removes the tooth topper, the patient has trouble breathing. You hear wheezing in all lung fields. Her pulse is 105 per minute. Blood pressure is 174 over 78 millimeters of mercury. Respirations are 33 a minute, and her oxygen saturation is at 92%. So she is in tachycardia, heart's beating too fast, and her oxygen saturation is lower than we would like. You correctly hypothesize that smooth muscles in her tracheobronchial tree are contracting, causing bronchial constriction and resulting in decreased ventilation. 15 minutes after administering albuterol via a nebulizer, a short-acting beta-2 agonist. So this is going to cause bronchodilation or open up those bronchioles. Her pulse lowers to 83 per minute, respirations are 20 minute, and her oxygen saturation returns to 97% on room air. So she has gotten a lot better. So what is the most proximal structure of the tracheobronchial tree without cartilage? Is it trachea, the primary bronchus, tertiary bronchus, conducting bronchioles, or terminal bronchioles? Oh, I see it now. Cool. Thank you. Whoever fixed that. So remember, it wasn't until we got to really far down that pulmonary tree before we finally start losing that cartilage. So we got 70% participation, so we're going to end the poll. And we see C, tertiary bronchus is the most, but actually it is, share the results. C, conducting bronchioles. So from this slide here, remember that the conducting bronchioles show no cartilage around generation 11 of the tree. Okay. Oops, close that. All right. So which of the following items has a similar diameter as a conducting bronchiole? A, your thumb. B, a McDonald's straw. C, a grain of sand. D, a human hair. Or E, Escherichia coli. So just to think your thumb, I don't know, it's about a centimeter-ish, and a McDonald's straw, probably about, say about 5 millimeters-ish. Grain of sand is 1 millimeter. A human hair is much less than that. And E. coli is, we're talking microscopy. All right, we're almost there. Cool. Okay, we're going to end the poll. And most people said B, but it's actually closer to a grain of sand. When you get down to that level, these are only 1 millimeter wide in terms of the diameter of the lumen for your bronchioles or your connecting bronchioles. So, all right. Case 2, a 57-year-old professional yoga impressionist presents to the emergency room with chest pain, shortness of breath, and increased work of breathing after angering a Darth Vader impersonator, resulting in a lightsaber stab wound to the left lower chest around the anterior axillary line. He shows no significant medical history and takes no medications. Pulse is 92 per minute with a 1+ pulse on the left and a 2+ pulse on the right radial artery. So 2+ is what we consider a normal. So on the left, you're not feeling the pulse as strong. Respirations are 33 per minute, which is a lot. Saturation of oxygen is 94% on room air, which is normal-ish. You observe intercostal retractions and prominent scaling muscles on inhalation. So these big scaling muscles, you see them popping out. On auscultation, you hear no breath sounds from the left lung and a strange hissing sound when he breathes in. A full thickness or a third-degree burn measures approximately 2 centimeters wide and 8 centimeters long on the left chest. So here is the x-ray. And again, I don't expect you to know how to read one, so I'm going to highlight some things. So you can see this dark shadow here is the trachea. So let's highlight it there. And it is moved way over to the patient's right. So remember, an x-ray is looking backwards forwards, so things are reversed. This line here of the cardiac silhouette shows the heart is moved way over to the right. And this line here shows the lung tissue has moved over. So we see all this lung over here, but nothing over here. This is all empty space. So what is the anatomical cause of the patient's presentation? The burn created a hole, so when the diaphragm contracts, air enters in the thoracic cavity via the hole instead of the nose and mouth. Patient inhaled midichlorians from the Timu Darth, resulting in edema and edema of the pleura. An inhaled object cut a hole in the left lower lobe, causing atelectasis, which means a hole in the lung. The lightsaber stunned the left phrenic nerve, which is why the is more inferior than the right diaphragm. Or is it Mycobacteria tuberculosis? And started the poll. Whoops, sorry. Just so you know that it's on the left side here. And we're almost there. Let's see, one more person. All right. So I'm going to end it. Okay. Everyone mostly went for choice A. That is definitely correct. Okay. Sorry, when I click my screen, it advances when it usually selects that screen. So we'll stop sharing that. And okay. Case 2, question 2. At a minimum, what layers of tissue are disrupted to cause this pneumothorax, which means air in the thoracic cavity? A, skin, B, skin and intercostal muscles, C, skin, intercostal muscles, and endothoracic fascia, D, skin, intercostal muscles, endothoracic fascia, and pleura, or D, skin, intercostal muscles, all that, and the lung parenchyma or the lung tissue itself. So remember, this is the absolute minimum. And we're almost there. One more, I think will do it. All right, we got answers all over the place, but the correct answer is tip to the layer of the endothoracic fascia. And I wish I had a picture for that, and I am using free images, and I don't have one for that. So let's go to question 3, and this is our last question. Oh, go ahead.
Emilie, I do have well, I'll let you, sorry, I'll let you finish, and then I want to cover a few things in this case, but go ahead, finish the last question.
Absolutely. Okay. And then the last question. You correctly diagnosed a pneumothorax and decided to place an emergent pigtail catheter to remove the air in the thoracic cavity. Where is the safest place to make an incision? So what a pigtail catheter is, we're going to put a smaller tube into the chest to remove the air. So would it be between the clavicle and the trapezius muscle? On the superior side of the 5th intercostal space along the rib? On the inferior side of the 5th intercostal space along the rib? Inferior to the costal cartilage, or midline trachea in the cricothyroid membrane? And I'm going to bring up a slide that I did not cover coming in, but I think would help you here. Is that it? Here. So note that all the vasculature runs on the inferior side of the superior rib. And it's not where it's located, it's actually on the inside here, underneath this area right there, not in the space. So we got 5 people, so let's increase that and we'll get to the answer. Oh, let me show you the answers. Sorry. And I think 2 more people. And that's good enough. Let's share the results. And because of that slide, and I don't know if people were allowed to change the answer, but it's on that inferior side of the 5th intercostal space, so we don't damage that neurovasculature. So to give you the conclusion, give you a happy ending, after appropriately anesthetizing a patient and inserting a needle at the inferior border, all that is done. You can read that. He improves and he says, thank you. So here are the references, and special thanks to Drs. Mapes, Selsky, Walzer, Yoshioka, and a student named Schaefer to help me with this presentation. And then we're back at questions. So you had you want to bring up something about question 2. Okay, there you go.
Yeah, so can we go back to your image first?
Do I have the image? Yeah, let me go back. I don't think I have an exact one, but I got at least these muscles, if that works, Dr. Haggerty.
No, your chest X-ray.
Oh, the chest X-ray.
Do you
Okay,
have a
we'll come
chest
back to it.
X-ray?
Yeah, I'll come back to it. Sorry. And there. And let's.
Okay. Are you able to
I'm gonna get rid of it.
remove
Yeah, there we go.
Yeah. Okay, great. And then, sorry, can you go to the next question?
What is the anatomical cause of the patient's presentation?
So I wanted to see if you could elaborate a little bit more on the
Absolutely.
case presentation and choice A here.
Okay, so let me go back to another image that kind of will help with these with the ventilation here. So when we breathe in, the diaphragm contracts and the lung and the chest wall expands, which will increase the volume of the thoracic cavity. Well, if you have a hole right here, so when you breathe in, this diaphragm will contract, come down. So air will come in through here, but also air will seep in through any hole that's in the chest wall. And so what can happen is you're going to increase the pressure between the thoracic wall and the lung pleura, which is going to cause air to build up here. And if there's no way for the air to escape, you kind of create a valve with a lot of tissue. Sometimes you can have air coming in, but not coming out. That creates a one-way valve. So that air is just going to keep building up on that left side, moving everything over to the left or moving everything to the right. Does that make sense?
Yeah, thank you. And then one final thing, can you go to your, I think the next question I talked about, yeah, okay. So I do recall in question one, you talked
did I
about,
switch left and
yeah,
right? Or yeah, I did. I'm
yeah,
sorry.
go
I
back
was
to
on the right. I
question.
couldn't
Sorry.
find an X-ray for it, and I switched it over. So
No,
yeah,
it's
it's
okay.
on the left. My apologies. I thought I fixed
Yeah,
that.
so but I wanted to show too in question number one.
Yeah.
I forget your description of choice C, but
Inhaled object. Yeah.
yeah, the atelectasis is actually a means collapsed lung.
Right. It's a collapsing lung. So go ahead. You get to my bad.
Yeah, it's okay. I forget. I know you know this, but I forget what you said in the moment.
I said a hole in the lung just to pass through and move on quickly.
Yeah.
I didn't give an
So
adequate anatomy explanation, so go for it.
yeah. So I think you gave a wonderful explanation on what's happening here. But this word actually means collapsed lung. And what Emilie is describing is a disturbance in pressure in the thoracic cavity. So with the air leaving, not being retained in the lung itself, it is causing that collapse of the lung because of the decreased amount of pressure and the imbalance of pressure within the thoracic cavity itself, and specifically within the potential space, which is that pleural cavity. So then I want you to go to question two. So I want to just make a quick correction here. So your answer choice should actually be D.
Oh.
Because you have to basically, to allow a collapsed lung, you want to be able to poke through part of that pleura. You want to get into the potential space. Potential space or the pleural cavity that surrounds surrounds the area, right, of the lung itself and the thoracic cavity is going to be basically endothoracic fascia and then pleura. So we actually have to get through also the pleura as well to disrupt that. But I think these questions were great and in a very interactive case presentation, and we really appreciate you putting them together.
Not a problem. I thought there was a potential space between the actual visceral or the parietal pleura and the endothoracic fascia, but it's got to be within the pleural space itself.
Yeah, so the endothoracic,
okay.
Yeah, because you have the visceral pleura. We know we have the visceral pleura along the lung itself. That pleura will reflect along the hilum and continue along the thoracic cage as parietal pleura. And what's it's adhered to, the parietal pleura, how it adheres to the thoracic wall is by endothoracic fascia.
Oh, okay. So they're continuous, they're adhered to each other.
Yeah, it's like if so during Emilie, you should know if you guys have, I assume, gone through thoracic cavity dissections. So you can actually pull that connective tissue off the thoracic wall to take a closer look at structures underlying them, like the intercostal muscles, like looking at the back of the thoracic wall. The being able to pull that tissue off the thoracic wall is actually the parietal pleura bound to endothoracic fascia.
Okay.
So it's
this would actually be the visceral fly.
Yeah, that's going to be the visceral pleura on that lung, the shininess on the lung. So when we're talking about pleura, we're talking about the lining within that thoracic cavity and along the lung itself. We also call it mesothelium. So it's a simple squamous epithelial layer. And if we recall, simple squamous epithelium is a single layer of tissue. So it's extremely thin. So when we look at the lung, it's really what gives the lung that shine. when we look at the pleural or the thoracic cavity itself, and again, if you were in lab, you'd be able to take kind of that tissue off the wall. It's not because you can grab onto the parietal pleura. That's only a single layer cells. It's because that parietal pleura is adhered to the endothoracic fascia, which is thicker. It's thick, it contains collagen fibers. So we're able to grab both of those structures and pull it off of the wall. And then again, a potential space. So under typical conditions, non-pathological conditions, yep, exactly. We create a pleural cavity between the parietal and visceral pleura. And again, those pleura or mesothelia will secrete a little bit of viscous fluid to allow for movement and prevent friction. But in Emilie's case presentation, what happened, we poked through that layer, allowing air to escape into the pleural cavity. So now it's no longer a potential space. The pathological element in there is air, and we have a pneumothorax. And then I do see that, Sammy, you have put a question in the chat, and we can try to help you answer this. But you asked, wonder, will the patient have peaked B lines from this or just a pneumothorax? So can you explain to us what you mean by peaked B lines, Sammy? If you're willing, or in the chat, or you can unmute yourself.
Oh, hey, you caught me there. Sorry,
I caught you there.
I was eating. That's my bad. Yes. Ooh,
You're allowed to. You
my
don't
bad.
ever apologize for
I did
eating,
that.
Sammy.
Swallow first. Okay.
My bad. Okay, so what I meant by that is mainly like in an X-ray, will B lines show up during like
Oh, like curly B lines?
right?
Let's take a look, actually.
Like I know they develop like sepsis from it, or because it looks like they swallowed or inhaled.
On this picture, no, these are little these are the EKG knobbles on the outside.
Oh.
Problem with the X-ray, you see everything in every layer, and they're always hard to look at.
This is every case, right?
Yeah.
Is this the lightsaber?
Yeah, it's a lightsaber case. Yeah, I don't see any curly B lines. Sometimes you can, and it's really indicative. Sorry, I got to pull up my pulmonology. I don't want to give you wrong information. But yeah, that you can definitely see that in certain conditions. I just don't remember off the top of my head what they were.
Okay. I'm guessing
it's been a year since my respiratory.
I know it's when there's fluid built up, but I just didn't know if that would be that would be more like a hematoma than a pneumothorax or a pneumothorax. I guess not a pneumothorax in this case. Never mind. I just thought
have a chylothorax.
Well, I knew it could be like a I thought at least since there was like a burn in the lungs, it would probably be a built up of blood or fluid, but I didn't. It was a pneumothorax, so I just.
So that's what I'm also seeing that peaked B lines are usually shown on ultrasound, not on a chest X-ray. And it does.
The curly B. The peak B. Sorry, I thought you meant curly B. Okay.
Yeah, I was talking about curly B.
Okay.
Yes, ma'am. I was talking about curly B.
Okay. So what we're talking about for the rest of the individuals in the chat and on here, it's okay. It's so we're talking about different types of things that we can see upon imaging. So a peak B line is something that occurs in ultrasound, and it shows up really bright when there's fluid around the lung. I'm not sure what you guys are referring to. It sounds like you can see it in a chest X-ray, and it also coincides with lung and some pleural effusion. So pleural effusion being fluid around the lung. I would say that that's not something you guys all have to worry about. I think Sammy always comes in with amazing clinical questions. It's not, no, don't apologize. It's all about experience and what we can bring to the table and kind of showcase for everybody. I will say, though, we need to move on to our next session. Thank you very much, Emilie. That was a wonderful presentation. If we do have more questions from Emilie, please put them in the chat or we can address them afterwards. But I'm going to hand it off to Dr. Frank to announce our next presenter.
Okay, happy to do so. So talking about the histology of the respiratory system, we have Deeba Mohseni. Deeba is from Johnson City, Tennessee. She graduated from East Tennessee State University in 2022 with a BS in Human Health and minors in Music and Culture and Health. She is currently a second-year medical student at the Sidney Kimmel Medical College with an interest in pediatrics. In her free time, she likes to bake, play soccer, and hang out with friends and family. So, Deeba, the floor is yours.
Thank you so much. I'm going to start sharing my screen. Hopefully everyone can see that. Alrighty, so after that great presentation from Emilie, see how much we know about histology. If you kind of think that everything looks the same in histology, you are in great company tonight. So these are your learning objectives that I'm sure you know about. So let's start with question 1. What is the type of cartilage? What type of cartilage is found in the trachea and the bronchi? We'll do the same. We'll wait until we get to 70%. Okay. Alrighty. There is your results. And looks like the majority of you chose C, which is correct. So great job to all of you. We will stop sharing that. And we're going to do a little follow-up question before we have some explanations. So which of my little boxes here would correspond to the hyaline cartilage rings that you would find in the trachea? All right. So it looks like a lot of people chose A. However, the correct answer here is D. So now we'll just go through a little bit of this histology here. Um, so I really like this picture because I find that like on the histology slides, it all just kind of looks the same. So I think this with like the colors and everything and like the kind of cartoony pictures really helps you to see like the differences in the types of cartilage. So you can see here that this hyaline cartilage you have, and if you remember, that is what is found in the respiratory system in the trachea and the bronchi. You have this ground substance that looks a little bit clearer, and then you have fibrocartilage, which is like it's very dense and you can see like the collagen fibers themselves. And then the cells look like very flat. Um, and then in your elastic cartilage, it's just kind of all over the place. There's no like real organization to it. And then this is kind of what you would see in actual histology slides. So this right here is your hyaline cartilage. So let's see if we go back to this picture. So you can see you have your cells in this like clearer background, which corresponds to this more cartoony type picture in this one. And then this is elastic cartilage, and I apologize that they're not in the same order as they were on the previous slide. So this elastic cartilage, which is similar to what you would find your auricle of the ear, which is just like this outer part. And so you can see like there's no real pattern to it. It's just kind of a little bit everywhere. And then this right here is your fibrous cartilage. And so you can see it's like you have the dense layers of the collagen, and then your cells are a little more flattened and a little bit more organized. So let's check the chat, make sure no one has any questions about this. Yep, thank you, Dr. Haggerty. Alrighty, next question. So which layer would contain the smooth muscle? Sorry if the picture is confusing you. There's not supposed to be any boxes on this one. Just like having a little picture sometimes. Maybe if we can get one more, then I'll close the poll. All righty, thank you. All right. Oh, it's even split on that one. So let's see the correct answer. And that would be the submucosa. Um, so the submucosa is this right here. And that, as you can see, has like the kind of the smooth muscle that you guys have learned about in previous lectures. And then you can see again here is your hyaline cartilage. So you have this like glassy substance in the background with your little cells. And then here again, we'll just kind of look at this picture. So this is your epithelial layer, and then right under it, you have that layer of smooth muscle, and that does correspond with the submucosa. So question 4, which
Hey,
of the
Deeba,
following points? Yes,
I'm so sorry. I gotta take you
you're
back a
good.
little bit.
All right.
Um,
Uh-oh.
I just wanted to talk a little bit about just I think you're doing a great job. I just wanted to kind of clarify a little bit too. We're looking, we're in the respiratory system, right? Um, so think about that, and that'll help you also think about the cells that are, let me see, do I have I don't know where my tools are to write on the screen, but yeah, there you go. Thank you, Deeba. So the epithelium too, we can think of as within the mucosa. So that's why it's not epithelium, because it's contained within the mucosal layer. But another way to kind of remind yourself is if you go down a little bit and you see where the glands are, Deeba, can you point those out? Yeah, like in this area here. That's also a part of the submucosa. So to kind of help orient you a little bit, you can look for those glands, and again, just like Deeba says, smooth muscle is also contained directly underneath um, that as well, the epithelial layer as well. You may also find some of it if you go a little bit more inferior to that as well. But what other connective tissue can we find here? You guys can answer in your chat if you like. There we go. Can you show them where the submucosa is again?
Yeah,
Like
this right here is
this.
the submucosa.
Well, the
This
whole
whole
area
area.
is, yeah, there you go. Like from hyaline cartilage up to the epithelium, like right in between there.
Yeah.
So just for the sake of time, you might also find some collagenous um, fibers in here too, collagen fibers, aiding to the structure of the trachea. Okay, sorry, Deeba. You're doing
You're
great.
good.
Go ahead.
No problem. Alrighty. So yeah, so just on like a different histology slide, what we were talking about. So these are the glands right here, and then kind of like this area starts like your hyaline cartilage. So then your submucosa would be everything from like right above that hyaline cartilage to like right below, like right where the epithelium starts. Hopefully that clears things up. So now we'll go to our question. Which of the following is a type 2 pneumocyte? Once I end this poll, I'll go back and I'll point out the mucosa again. Alrighty. Still answer if you're working on that. Um, Let me go back and point out the mucosa one more time. So the mucosa is kind of this layer that has the epithelium. So submucosa, everything from here to here, and then mucosa is everything from that top border of the submucosa up. So now, see, we will end this poll. Looks like the majority chose A. Um, and we will, so the correct answer was B. And then we're going to have just one more question, and then we'll go into the explanation for that because I know that can be kind of confusing. Yes, the mucosa does contain the epithelium. I don't know if the poll is good. There we go. All right, a couple more people to answer. Like you guys are doing great on this one. All right, let's end this poll. So the majority of you chose C, which, if I remember my labeling, is the correct answer. So let's go over the type 2 pneumocytes. Just starting like very broadly, I always like looking at these cartoony pictures because it gives me a better sense of like what I'm supposed to be seeing. Um, because when I look at the histology slide, I don't actually see anything. So this little cartoony picture will kind of help you just kind of get oriented. So this is um, one alveolus that has been blown up a lot. And then in this picture, you have this is one alveoli. Um, and then you've got what's called an alveolar sac, which just has it's a bunch of alveoli kind of together. So you've got the type 2 alveolar cells that are right about here. You've got your type 1 cells kind of at the edge of the alveolus. We'll look at this question now. So what is the function of this tagged cell? Um, Hopefully the giant arrow helps you see what I'm pointing at. This one's a bit more difficult because it's just a picture of a cell and it can kind of look like it's just about anything. Ready? We can get a couple more people. Alrighty. Uh-oh. Looks like the majority of you chose B. However, correct answer in this is C. Um, Again, I know this is difficult. This is very just everything looks the same. But we will go through this. Yeah, let's do this question first, and then we will go back over questions 6 and 7 together. So for this one, oops, we are going to figure out which one correctly pairs cell types with their functions. We can get a couple more people. Alrighty. We'll go ahead and end this. Looks like the majority of you chose B. And we'll move on. So yes, that was the correct answer. So your type 1 pneumocyte does your gas exchange, and your type 2 produces your surfactant. Um, a good way that I like to think of it is the flatter it is, the easier it is for things to get in and out. So if any of you like to cook, like if you think about like the thinner you make something, like the quicker it cooks. Whereas if it's super thick, then it takes a lot longer to cook. And when you're doing like your gas exchange and stuff, that's really, if you think about it, like it's a very quick process. So you're doing this exchange of the gases very, very quickly. So you don't want your gases to have to go through like this very like tall cell. It takes a lot more energy. It'll take a lot longer, and it's just kind of inefficient. Whereas your type 2 pneumocytes, because they're producing surfactant, um, if you think of it as like when you're producing things and it's like a factory, like I've never seen a small factory. So I would assume all of them are huge. So um, your factories are more of like your like they either got to go out or have to go up. So that's how I kind of like to think about it. That it either has to be like cuboidal, so like a little more wide, or it has to be columnar, so like very tall. You just have to have enough room for all that stuff. Um, and then we will go back to question 6. So this cell right here is actually an alveolar macrophage, and we will point it out right here. So that is your alveolar macrophage. It's hard to see on this slide right here. For this question to find this, I'd have to search through the slide a good bit. So sometimes they're hard to see, but best way to spot it is they're big and they're speckly, and honestly, this is the one time that I will be like, this does look different than the other things. Um, so this one cell does look different from the other cells that you would see in this slide. So, and if you think about it, when you're kind of similar to the principle about like the production and stuff, um, phagocytosis, for those of you that you're hearing that word and you're like, I just can't remember what it is. That's the process of like your cell, like there's a pathogen and then your cell comes around and it just kind of eats it and it digests it. And it's just doing away with all the bad parts. Like if it's just a cell that has lost its function and it's, trying to get rid of everything, or if it's like a bacteria that you're trying to get rid of. So you do need something that is like kind of like a bodyguard. They got to be big and strong. So this is your big and strong bodyguard. It's protecting the lungs. Um, and then let's go back to this picture. So that is your um, macrophage. And then you can kind of see in this picture, your type 2 alveolar um, cell is just like a little bit taller. And that's for the surfactant production. And then your type 1 cells are very, very thin, so that you can get that good gas exchange quickly. Um, and then for this question, um, just like how Emily went over, this A corresponds to the trachea, B is a bronchi, and then I tried to make it point to one alveolus if I could, but that was the best I could do. They're small. So this is supposed to be pointing to an alveoli, which is, if you guys remember, that's where you have like your gas exchange. So that is where you would find not only your type 2 pneumocytes, but your type 1 as well. And then, so yeah, so that is how, so if you, either you can remember like type 1 is flat, and so therefore it should produce gases, or sorry, it should exchange the gases, or you can remember that type 1 does the gas exchange, so therefore it should be flat. Either way works. And so this is like very generally within the respiratory system, your squamous cells have to be very flat. Well, everywhere your squamous cells are flat. In the respiratory system, they're flat for gas exchange. throughout your body, it's like kind of they're flat like for other types of exchange, but for your respiratory system, specifically, it's for gas exchange. Your cuboidal cells are just like a little bit taller, and that is everywhere. And then in the respiratory system specifically, you have your cuboidal cells that produce and like excrete substances. And then macrophages always, always, always for phagocytosis. And that again is just the digesting of the bad things and all of that. So I believe that was
You have a
my last
question.
question.
You have a question in the chat about macrophages.
Yes. Do alveolar macrophages consume dust that gets into the alveoli? Yes, I believe that it does. The alveolar macrophages kind of consume like anything that's not supposed to be there, um, including like dust. And if you're just like, just, living as a person walking outside, there is some pollution. So I believe your alveolar macrophages also try to deal with that the best that they can.
And then can you address the second one too?
Yes. That's taken care of by ciliated pseudostratified columnar epithelium. Okay, so the you are on the right track. So um the cilia do kind of I'll stop sharing my screen. So your cilia beat to kind of like move things in and out. So well, not really in, mostly out in the sense in the respiratory system. And so if you're sick and you are coughing up all this like thick mucus, your cilia is beating to get all of it out. It's supposed to just kind of like sweep and clean the area. Um, so that's kind of the difference. There are some diseases where like your cilia just don't work very well. And so oftentimes like they have to get like manual treatments for like helping to move the mucus out of their lungs. So yeah, I hope that made sense. Yeah, cilia
Yeah.
macrophages work together.
Yeah, that was perfect, Deeba. So if we're higher up in our respiratory tract, that's where we find the ciliated pseudostratified epithelium. And Deeba is 100% correct. It has cilia. It also has goblet cells that produce mucus, and it helps trap the foreign things in bodies to expel them out. Whereas if we have anything that gets past that point into our alveoli, there's also macrophages. If you Google this, it actually comes up as alveolar macrophages are also called quote unquote dust cells. And there's actually, I almost ended up in a lab in my PhD thesis that looked at macrophages, alveolar macrophages, and sex differences, and looking at like asthmatic individuals and what dust does. Harry Potter and the Goblet of Surfactant. You're on a roll today. So I think these are all really great conversations. I did want to address a couple things higher up in the chat. So we had talked about the different layers. So mucosa, submucosa, and then you can see a hyaline cartilage and adventitia. So Emilie and I were kind of talking about, do you need to know the difference between what an adventitia and a serosa is? So these are both coverings of organs within the body. How I kind of like to think of it as serosa is actually the same thing as like the mesothelium. So if you have anything covered by mesothelia, which is the pleura, in our GI, it would be peritoneum. Around the heart, it would be the serous pericardium. These are all things like serosa. Whereas you can have other areas that aren't necessarily covered by the mesothelium, but they still have connective tissue covering them, adhering them to other surfaces. This is adventitia. It's not something we really need you to hang your hat on at this point, but there is a difference. So you'll hear, but if you ever see us say serosa or adventitia, it's a lining on the outside of the organ. So when thinking about the question was, is it superficial to deep? I would think of it, is it closer to the lumen or further away? Because we can have lumens deep in our body, right? We have a GI tract, which is like in our abdomen. So for the trachea itself, if we're in the trachea, the closest thing to that lumen, the opening of the trachea, is going to be the mucosa. And as you get deeper into the body, if you want to think of it that way, or further away from the lumen, then that's where the adventitia is. The last thing, which again, as Deeba was talking, and I'm happy to hear a quick comment from either any of our tutors, and I'll make one myself, is there's a couple of things in the chat saying, oh man, I'm not ready for medical school. You can do anything you put your mind to. And I want to say too, as far as the anatomy competition goes, first and foremost, I believe all of you can become doctors, health professionals, biological engineers, art teachers, anyone who wants to work on what am I trying to think? A dentist. I can't think of anything but art and medical school right now. But if you want to go work for the state, whatever you want to do, whether you do this and decide to go into the health professions or do something completely different, you can do it. If you want to do it, you will do it. We are a resource. I want you to come into this competition, we want to challenge you. These questions are challenging. But I don't want you to be afraid. I want you to tackle it as best as you can. And I want you to use it as a major learning opportunity and a major opportunity for experience. No one here is judging you. No one here is worried about you getting the correct answer. And even when you come in to do the competitions, we give you a final score, and those who score the highest will win a financial award, or be invited to the regional event, which is where we give the financial awards. But in no shape or form are you evaluated as a person on this. The fact that you show up and that you do this is, you should be immensely proud of yourself, no matter how well you do on these questions or not. You are learning and you're experiencing, and that is actually what Anato-Bee is all about. It's not about how well you do. It's about you experiencing something phenomenal and something for everyone to experience. So I just want to put that out there. Please do not feel this makes you less than a person or anything like that, because you're not doing as well as you thought you are doing. We already think you're doing truly amazing because you showed up. So if any of our students, medical students here that are teaching you today, have any words of encouragement for continuing into a medical degree, and about those feelings of like, I can't do this, if you can just give a quick, before we have Brian go, sorry, Brian, but just like a quick tidbit, that would be amazing.
Yeah, I will say you guys are already way ahead of where I was when I was in high school. Um, I would say that that's true for like most of my classmates, if not most of the medical students in the United States. Um, and I, when I was making my presentation, I had to like go back and relearn all of this. So it is not something that you just like look at it once and all of a sudden you're an expert. Um, But if it's something that you really want to do, like you can do it. And I think what's more important, like to being a good like clinician or healthcare provider than like doing well on a test is like being a good person and caring about your patient. Um, that is like, I think that that is like the core of it. And if you have that, then you can learn, like the learning is, you know, it's difficult and it'll take a lot of hard work, but um like you will learn it. You're not just going to like show up and not learn anything. They will the Your faculty will help you, and you will be forced to learn it at some point. um but if this is truly what you want to do, and if you care about people and your patients, then I think that's the most important part.
Sorry, I can go. I just lost my mouse. I'll tell you a little bit about myself. I'm much older than I think all the other students here, and I'm only the second oldest in my class. But I failed out of college. I made some mistakes. I picked the wrong path. I got into financial trouble, and then I kind of wandered around, did life for a while. I did graduate from college. But yeah, I had flunked out. I went back to do a postbac. It took me 2 years. I did very well. I did well on my exam to get into medical school. So it's a learning process. You gotta, like, if you're gonna take the MCAT to get into med school, you should know a little bit about biochemistry. But before you do biochemistry, you gotta learn a little bit about organic. And then before that is your general. And before chemistry, you should know what a science is and know a little bit about math. And so you're building these skills. And eventually you're gonna get to that level that this is going to start to click. And that's going to be a college degree, and it's not even a couple years of med school before you start really understanding this. It's going to be hard. It's going to be challenging. And I would highly, highly, highly recommend you go shadow or talk to doctors and see if that is the way you want to go. It is so expensive to pursue a medical degree, and you cannot change your mind once you go. You can, but it's so expensive to get out because you're responsible for that money and you got to pay it back, regardless whether you finish or not. So make sure that's what you want to do so you don't get stuck. Because there's a lot of doctors who are unhappy and feel burnt out. But if this is the way you want to go and this is what you want to do, and you don't have any ego, and this is the thing you want to do is to help other people and help patients, definitely pursue it. It's gonna be the best job you'll ever have. So that's my 2 cents. But yeah, build up those skills. Be a kid first. Go through college, and you'll learn some stuff, cool stuff. And you may think of the other things you want to do, but if you want to do medicine, it'll be there for you. And get through college first.
All right, awesome.
Right.
Thank you so much for that. So I guess I can just maybe lead into my presentation. I'll go ahead and get my screen shared. Can you guys see this?
While you're doing that, Brian, let me introduce you properly.
Sure.
Is that okay?
Yeah, I'm
All
jumping
right.
the gun a bit. My bad. Thank you so much for that.
No problem. So our next presenter, which will be covering the embryology of the respiratory system, is Brian Nguyen. Brian is from Fairfax, Virginia. He graduated from George Mason University in 2019 with a BS in biology and Eastern Virginia Medical School with an MS in biomedical sciences in 2021. He is currently a second-year medical student at the Drexel University College of Medicine in our very own West Reading campus. He is exploring the specialties of hematology, oncology, pediatrics, and surgery. In his free time, he enjoys playing video games and cooking and loves listening to EDM. That's electronic dance music. Is that right, Brian?
Yes,
I
there
lost
it
my notes.
is. Yeah,
Okay.
EDM is electronic dance music.
Yep. So his favorite unit in anatomy is abdominal and GI anatomy, a really interesting and digestible topic. So
All
without
right.
further ado, we will listen to Brian give his tasty presentation on embryology of the respiratory system.
I think someone else made a mention in the comments about puns, and I just want to say, like, think talking about the stress of medical school and then the stress of all of this stuff that you guys are going through. Guys, remember, we're in the respiratory system. Just remember to take a breath. I honestly, I will just want to throw in my 2 cents. Every single day I go to class and I'm like, oh my God, I forgot to study that. I forgot to study that. I went to bed when I probably should have stood up. I was just like, oh my God, I don't know what I'm doing here. I doubt myself very often. But it's something that remember that every day you got to remind yourself that you've survived that feeling every day and you've still done it and you're still trying. So give yourself the credit and the grace that this stuff is super freaking hard. And with that being said, let's start talking about the embryo system. Embryology of the respiratory system. So here are your learning objectives, and then there's the link to the video. Okay, and we'll start off with a nice little overview of what we have with our embryology so far. So it's a huge topic, and we went through so much. So let's just briefly go over what we have so far. First off, you have that act of fertilization, morulation, where you make that ball, and then implantation, where you implant that ball of cells that's hollowed out into your endometrium of the uterus, right? And that all happens in week 1. In week 2, that is our week of twos. That is when that implanted ball is going to cavitate and then make 2 layers. It's going to be kind of like one cavity, 2 layers, and then like that initial cavity. And then what's going to happen is that's going to lead into gastrulation, where that 2 layers is going to sort of it kind of like opens up like a pita pocket, and then those cells start to move inwards with that epithelial to mesenchymal transition, guided by that primitive node and streak right here, which eventually leads into the development of the notochord and which signals the development of the neurulation of your neural tube, right? And then finally, we take that pancake of three stacks of cells with like a bunch of other stuff on it, and then we fold it inwards for embryonic folding. That's what gives us essentially our body tube, our three-dimensional structure with our inner gut tube. And that actually overlaps with our respiratory development, which starts around the end of week 3. And we're going to start off with this question. So I'm going to ask Dr. Frank, can you go ahead and start the poll for us, please? And this is going to be your first question. So by the end of week 3 of human development, a small outpouching or groove begins to form in the foregut. What is the name of this structure? All right, let's get a couple more responses in, guys. We're looking for 60% participation, Dr. Frank. Give or take. Okay.
70.
All right, let's go ahead and close it then.
Yeah.
All right, so let's start talking about our first step of respiratory development, and that's going to be the formation. This structure is the formation of the respiratory diverticulum. Oop. Respiratory diverticulum, right? So let's just go over these. Lung bud, a little too early for that. Tracheoesophageal septum, we'll talk about that in a second. And visceral and parietal pleura, remember that's those are our serous membranes, our visceral, where we have our pleural cavity. That's where it's going to surround our lungs. Type 1 pneumocytes is just going to make up our lungs. That's not bad, so we're not going to look at that. All right, so and I see just a quick thing in the comment. The foregut is part of the digestive system. Yes. So let's go ahead and talk about that. So initially in embryology, we have our folding of our body plan right here. And then we have this gut tube, which is made up of endoderm. And then we have this mesoderm that surrounds it right here, right? Remember, our endoderm is going to make our structures of our gut. And we have three parts of our endoderm that we'll talk about later. That's going to be our foregut, midgut, and hindgut, right? And then our mesoderm, that's going to be our mucoderm. That's going to make a lot of our muscles as well as our connective tissue that connects those structures. Okay, so let's go ahead and talk about that and how this starts to develop. So this is the first stage of respiratory embryology. This is the embryonic stage, and this happens around weeks 4 to 6. And what basically happens here is you have this mesoderm that I showed before. This is just another angle of it surrounding this endoderm. And what happens is the splanchnic mesoderm is going to release retinoic acid. It's going to release some signaling factors that's going to act on the endoderm to sort of like pocket outwards and sort of branches outwards until you get this respiratory diverticulum. And then afterwards, it's going to grow and grow and grow until you get these lung buds. Okay, now these lung buds are eventually they're called tracheal buds, and well, they're called lung buds. They're making the part of the trachea. They're going to start to make our left and right main stem bronchi, followed by our secondary lobar bronchi, followed by our tertiary or segmental bronchi. Okay, and then that's all going to happen throughout the weeks 4 to 6. Okay, I just want to point out here's a nice little diagram showing that mesoderm or that the the visceral pleura and the parietal pleura that surrounds our lungs. And I want to point add a reminder that that comes from the somatic mesoderm. Okay, so with that being said, let's move on to the next question. Let's go ahead and get another poll started. Question 2, during the pseudoglandular stage of lung development, which structure is formed? Get a couple more answers in. And going once, going twice. All right. Okay, so I think I checked a couple of you guys. So this one is actually the terminal bronchi. So it's the terminal bronchi. It's important to note the pathway of the air and as it develops. So remember, you have your primary, secondary, and tertiary bronchi. I'm sorry, terminal bronchioles. I think I misspoke there. Terminal bronchioles. And it's important to know the pathway of air and how it develops. Remember, we have our development of our left and right mainstem bronchi, and then it stops right here at the terminal bronchi. People think like terminal is like the last one, but the last like bronchiole is actually the respiratory bronchiole. Remember it's the second to last is going to be your terminal bronchiole. And that's because this is technically the sort of like, I guess you can say the segue between where we move away from ventilation to respiration. Okay, and here's a good diagram of that. So this one's going to happen during the next stages. That's going to be between weeks 5 to 16. That's going to be your pseudoglandular stage. And that's going to happen because it's looks like glands, actually. Some genius, a couple, I guess, couple dozen years ago, thought that this looked like glands, but that ended up not really looking like glands, so they called it pseudoglandular. Um, Genius. So, and it's important to note that this is where we'll start to see the proliferation of our arteriolar capillary network, but this is still too far early to be thinking about. This is like still in the first trimester to be thinking about it being sustainable to life. Okay, and then that's going to lead us into question 3. So let's go ahead and get another poll going. In the canalicular stage of lung development, capillaries and type 1 pneumocytes can be seen, and both components of the air-blood barrier are needed for respiration. However, during this stage, fetal gas exchange is still not possible. What's the reason for this? All right, let's go ahead and call it. All right. So, okay, so we got some answers across the board. The right answer is actually D. So the air-blood barrier and surfactants are two separate components. Surfactants help it, but it is not a part of it. Remember, surfactants' purpose is to decrease surface tension, so it stops the alveoli from collapsing in on itself. You can still live without surfactant. That is just a severe critical medical condition that we'll talk about in a second. But the answer is because it's still developing its capillary network. So let's go ahead and take a look at the canalicular stage. So as those during these weeks, weeks 16 to 26, what you're going to start to see is the next development of your alveolar tree, your respiratory bronchioles, as well as your alveolar ducts. And then you're also going to start to see your type 1 pneumocytes start to flatten out into that simple squamous-like appearance where it's going to look like really flat like a pancake, giving it a lot of good surface area for that respiratory exchange, gas exchange. But however, it's important to note that the capillaries are out of reach. It doesn't matter if the patient was producing surfactant at this stage, if the neonate was producing surfactant at this stage, even if they were respiratory, even if they were breathing, the air just wouldn't get to the capillaries. So, all right, moving on, let's go ahead and hit our second to last question, which leads us into a patho one. So, and this one's talking about IRDS. So, infant respiratory distress syndrome is seen when premature infants do not produce enough enough lung surfactant with their type 2 pneumocytes during the saccular stage of lung development. This can lead to respiratory distress and fulminant respiratory failure. It is unsustainable to life. It is very dangerous and can progress very, very quickly. Patients who usually have this condition usually have very low APGAR scores when they are immediately born and require immediate mechanical ventilation. They'll still be able to breathe a little bit, but again, you need that surfactant so that those alveoli can expand. But anyways, what is the purpose and significance of lung surfactant? Oh, did I just answer? I think I just answered the question. Hopefully I did do that. Get a couple more answers in, guys. All right, let's call it here. Okay. So, yes. All right. So this one is that it decreases surface tension. Remember, surface tension is the tendency of those water molecules to stick together. And what's going to cause that to happen is this alveoli is going to be pulled in on itself. So surfactant is an important component of that. Let's just go over a couple of these other options. Increased chance of atelectasis. Atelectasis is alveolar collapse. So remember, it's going to prevent that. So it's going to decrease the chance of atelectasis. Pulmonary compliance is your ability of your lungs to, for lack of a better term, comply, stretch with respiration. Which is similar to elasticity. It's actually going to increase pulmonary compliance. It makes it easier to breathe. It's going to decrease pulmonary recoil because that lung surfactant is going to stop it's because pulmonary recoil is inversely related to surface tension. And I think just for maybe at that level, I think that's good for now. And we mentioned that it decreases surface tension. Okay, cool. All right, so moving on to our next stage. This is our saccular stage of development. This is where we're going to make our alveolar ducts and our terminal sacs. And it's important that this is separated by only a single septae at this point, right? So we can see here that we're really getting the formation of our air-blood barrier. Here's our alveolar sacs right here. You can see our type 1 pneumocytes. We can see where that basal lamina would be. And then we can, underneath this would be where our capillaries would be. So, with that being said, yeah. So this one's going to happen from weeks 26 to birth, and you're just going to see more proliferation of your alveoli and more surfactant. Okay? All right. Now let's go ahead and move on to our last question. During the alveolar stage of lung development, the air-blood barrier is further developed and matured. Which of the following is not a component of the air-blood barrier? It's the pole open, Doc.
I am so sorry. I clicked and the poll popped up and I hit the end poll.
Oh, no worries. I think we can get another one opened up. All right, poll should be open. Open now. All right. Okay, awesome. So let's go ahead and take a look at this. And now we get to talk about the air-blood barrier. Okay, so this one's going to be our type 2 pneumocytes. That is not a component, because remember, the components of our air-blood barrier are going to be our type 1 pneumocytes, the basal lamina surrounding them, and then the endothelium of our capillaries itself. And this is right here is how we exchange gas. So oxygen and carbon dioxide, hopefully not carbon monoxide, are going to be exchanged at this area. Okay, so now let's sort of maybe just go over yeah, okay, that's it. All right, now I want to point out that the alveolar stage of development happens from birth to around the 10th year of our life, and this is where we just see a continued proliferation and maturation of our lungs, right? This is where we're going to see an increased number of type 1 pneumocytes, further increase of type 2 pneumocytes, and then if the patient has any issues with surfactants such as respiratory distress syndrome, and it didn't manifest as infant respiratory distress syndrome, we might see this patients with surfactant issues often might also present at this time. And I just want to point out the four components of our type 1 pneumocytes, or four components of our air-blood barrier are right here in this little diagram as that. Okay, so with that being said, I'm going to briefly go back because I wanted to mention what stage it would be for if you were if you were a newborn rather, or if you were born early term. You can actually be born early term around the 28th week. That's going to be the end of the second trimester. That's because that's going to have enough alveoli with proper air-blood barriers to conduct gas exchange. And what happens actually at birth is that give or take around week 20, your lungs will start to work around that saccular stage, right? And then what happens is your lungs is going to start to contract, bringing amniotic fluid into your lungs. And then surfactant is then going to mix with that amniotic fluid and activate the macrophages that are residing in your amniotic fluid and in your chorion and cause it to move through your chorionic cavity to the surface of your uterus. And your macrophages actually produce prostaglandins that cause the cervix to soften and ripen, that help signal the body that it's ready for a signal to the mother that the neonate is ready to be delivered. Okay, so there's a sort of like interplay between our respiratory system as well as our as well as like the macrophages and stuff that like produce the prostaglandins that tell our body that we're ready. So I just thought that that was pretty cool to mention. So with that being said, that is all I got for you. Here are my references. And let's go ahead and open the floor for any questions. All right, does anyone have any questions?
And I wanted to, while people are thinking, you can ask questions in the chat or you can ask them, unmute and ask. Thinking back to if you can go back to the slide when you talk about lung bud development, basically. It's like at the very beginning. Yeah. Okay, good.
This
That one.
one, yeah.
Weeks 4 through 6. So I saw a lot of people in the chat. Yes, foregut, midgut, hindgut is how we separate out the GI system. But if you think, this is how I kind of remember that the lungs form from a respiratory diverticulum within the foregut. So if you notice, behind, and I think, Brian, you did a phenomenal job. So I'm just kind of putting out some ways that I think about this stuff. But if you notice, like in step 3 here, you can see behind the trachea is the esophagus. So that, remember that the GI and embryological development is literally like a tube. And if we think anatomically as well, like in an adult, where does the foregut start? Do you guys know or remember? You can answer the chat. Esophagus. Yeah. So like it starts higher up. And we also call this the alimentary canal, but it really starts like in the oral cavity, starts at the esophagus. So this is a good way to kind of think for the development, like, oh, okay, this kind of makes sense because during development, the foregut, again, a tube, is going at the very top portion is going to be the esophagus. That respiratory diverticulum will form out of it. And if it appropriately fuses away from one another, as they're showing again in that kind of third step here, I think they even call it a tracheoesophageal like septum that forms there, right? This
Yeah.
also makes sense because when we think later on in life, in our adulthood, when you look in anatomically, we have the esophagus more posteriorly, and then our tracheum more anteriorly. And this also is, if you've ever heard of a tracheoesophageal fistula, so during development, when these two structures are forming, it's when that septum doesn't appropriately form and there's an opening between the two structures. So again, these are a couple of just tidbits. I think Brian did a phenomenal job tonight. Thank you very much. But I just, when I see questions like this come up, my brain, I always try to take for everything, take it back to basics. So I'm just like, well, that's crazy. Why would the trachea, the respiratory system, form out of the esophagus? So I just kind of be like, oh, well, it kind of makes sense anatomically later on, but also like it's up towards the foregut, esophagus. So kind of putting all those things together. Um, does anybody else have any questions for Brian? Okay. And if you don't have any, and two, we can open the floor. Yeah, embryology is really something. And we can open the floor to everyone if you have questions about the content tonight. If you just have questions for our lovely students who came and presented tonight, thank you very much. And it can be on anything. I know we had some really great conversations in the chat about just, and motivational chats about getting into med school or anything you want to get into in general. And if you have questions for us, we're here. So you are welcome to go, or you're welcome to stick around and ask us questions.
Before people leave, just wanted to remind them that our next session will actually be next Sunday evening, not in 2 weeks, but actually a week from tonight.
Yes, thank you, Dr. Frank. That is a good way to end the session. And also have a happy Thanksgiving if you are celebrating Thanksgiving, and not, happy gatherings and relaxations with your family, because everyone deserves a break. Nice. Sorry, there's a person in the chat saying their sister's mad for them hogging the computer. Have her join in.